quite outstanding. Let us welcome Dr. Lester Thompson.
Thanks very much. Actually, speaking of the CV, it is funny, when I applied to work at Kaiser initially, I had sent my CV as a two-sided printing in order to save paper. And when they scanned it, they only scanned one side. I still got the job, so I guess it didn't really matter. Okay, let's talk about towards extinction of NOS. You know, the not otherwise specified is, of course, why we always have tumor classifications and how we reach them. And so this is going to be a very high-level whirlwind update of the 5th edition for the head and neck book specifically. And just to say, I obviously was on the editorial board as one of the editors, and have been on the standing board for the last several years, and do have several publications as well. So, if you don't know what the name of something is, the knowledge of them is going to be lost. And this was Carl Linnaeus who came up with the very first hierarchical system for identification. But for us nowadays, giving the correct name to the various cancers means that we are ready to be able to defeat them. So if you think about it, the WHO has been around for a long time, and starting back in 1956 actually started the first classification, with the blue books being an evidence-based system for the classification. And this underpins all of the patient treatment and management with prevention and therapy and so forth. But it's definitely not just for pathologists. And so I'd encourage you to try and be able to go and look at these books as well. So just in general, for the 5th edition, there was a very massive overhaul of both the governance, the quality and standards, as well as the production. They used a computer algorithm with AI involved in bibliometric evaluation to come up with the authors. So more than 2,500 people were involved in the 5th edition as a whole. There's major linkages now to all of the various organizations that are involved with cancer management. So the coding system with ICD-10 are now integrated. Staging, AJCC and UICC are incorporated as well, with genetics and other organizations. And then I think one of the major efforts has been to harmonize the terminology across the entire series. So in other words, the criteria used for a specific diagnosis in the lung are now the same criteria that should be utilized were the lesion to occur in the GU system or in the head and neck or somewhere else. This is primarily for neuroendocrine tumors, hematolymphoid soft tissue, and familial syndromes. And then trying to get everything standardized to metric system using mitoses per 2 square millimeters rather than a high power field, which, as you know, changes quite frequently. And then the website is absolutely fantastic, because the amount of information you can store on the website is obviously going to be quite different than what you would have otherwise, and therefore is really quite a positive aspect to have. So this is just an example of one of those major organizations with whom we have linked. It's the International Cancer Reporting Agency, or ICCR, and they all have data sets that are now used globally. They are free of charge. Anyone can use them. So they are not the for sale aspects that come from places like the CAP here in the United States. So, I do like to put things in context a little bit. And if you think about it, here I was in 2003 at the July classification meeting of the 3rd edition for the WHO. And if you look at that, I didn't change at all in my position. I was still inside, still in the same number of people in from the left-hand side when we met in 2016 for the 4th edition. And unfortunately for the 5th edition, Zoom has taken over just as it has here. And here were all of the members of that particular editorial board. So interestingly, there were only 5 editors for the 4th edition, and yet we now had 19 for the 5th edition. So this tells you it's a greatly expanded number of people, and this specifically because we were trying to get as many individuals globally to participate. You will notice that there are 4 people in yellow. They are standing board members. So in other words, as a standing board member, even though I was considered, quote, an expert for the head and neck, it meant that I would harmonize terminology. So a breast adenoid cystic carcinoma actually has the same diagnostic criteria as we do for the salivary gland, because I made sure that that was what was implemented in that organ, and the same thing back and forth. So this means that everything across the entire WHO has been standardized in that regard. So overall for the book, 253 unique entities, 288 authors, and 35 countries involved. And this is the first time that the hierarchy actually goes logically. So it starts with hamartomas or reactive tumor-like lesions, just because they can present as a mass or tumor clinically. So some of those were included for differential purposes. And then going to benign neoplasms, borderline, and finally ending with the malignant. And in the malignant category, trying to go from low to high grade. And if grade was not important, then going by frequency of occurrence. So I think the most significant change for all of this, and something that you guys should really be aware of, is that there's been an aggregation across all anatomic sites for things that are similar, so that there is not going to be redundancy. So the very first thing, salivary glands. If you think about ear and temporal bone, there's salivary gland related tumors there. If you think about larynx or sinonasal tract, you clearly have salivary gland like tumors in those locations, but they are now not repeated. So there is only one chapter devoted to salivary glands, and even though they may occur anywhere within the anatomic sites of the upper aerodigestive tract, they are not repeated. Same thing with the soft tissue lesions, hematolymphoid, melanocytic, and metastases. So each of these now has its own chapter without it necessarily being repeated in other anatomic sites. So were you to go and look in the hematolymphoid, let's go to anatomic. If you looked at nasopharynx, you would not see any of the hematolymphoid malignancies there, and yet we know certainly the B-cell lymphomas are quite common in that location. So it was a way in which to try and not have such a lot of repetition and expand the overall volume thickness of the book, but instead have a much more in-depth approach to each of the various chapters. Very, very major overhaul with neuroendocrine tumors, and I'll discuss that at the very end. And then, of course, the addition of the genetic tumor syndromes as well. So if you go to tumorclassification.iarc, which is IROC for the publisher, .hu.int, you'll be able to actually see all of the books there at once. Obviously, the head and neck book has not yet actually been printed, so it is still considered beta. I apologize for that. The person who's doing much of the editing got pregnant and had major complications, and so it's delayed the book by several months, but it will come out. And the beta version just means that it is online and you can still use it in that particular setting. So I think the best idea of the online version is you can go to it anywhere. You can be on your phone, you can be on your desktop, so it's kind of an on-demand access. There are many more images in the online version than what we have in the printed book, just for clarity of space. So if you really did want to see something, you'd be able to see it a lot better there. There is a virtual whole slide for every single diagnosis. So this means that no matter what the case is, if you actually wanted to see what a histology of that lesion looks like, you would be able to drive the slide virtually. Clearly, you cannot do that in a book, but with the online version, you're definitely able to do it. Each of the references has a PubMed ID associated with it, and you can click on it. It automatically launches you into PubMed so that you're actually able to see the supporting documentation that allowed for that particular data point to be entered into the book. So it's a very nice supporting correlation of the findings that you have in the book. And then, of course, all of the tables are there as well, and I'll show a few of those as I go through this presentation. By the way, that is not the cover of the book. I am going to say this is my mock-up of what the cover should be. Ultimately, there will be a cover and we'll see what it's going to look like, but at least you have a virtual version at this point. Okay, let's dive into where we're going to be with each of these, and I'll go over them as quickly as I can. So you'll notice in each of these sort of separating cards, I've put in what happened in 2005, 2017, and 2022. So you can see that there have been various intervals between when they were published. But I think what is even more interesting is that you'll notice there were 69 diagnoses in 2005, and we're down to 24 now. Now, it isn't because there are fewer entities that occur in that location, but it's just those that are specific and unique to the sinonasal tract are the only ones that have now been included there, whereas all of that redundancy related to salivary gland or hematolymphoid, soft tissue, etc., has been removed. So just be aware of that. If you go and look at something and you're like, oh my God, they don't have melanoma, why didn't they have melanoma? It's because it's in the melanoma chapter. Okay, so two new entities, the SWE/SNF complex deficient sinonasal carcinomas and the HPV-related multiphenotypic sinonasal carcinoma. Two emerging entities of the IDH2 hotspot mutation tumors, as well as the DECAF2 carcinoma category. And then, some updates with some of the other tumor categories as well, like teratocarcinosarcoma and sinonasal adenocarcinoma. So just briefly, the SWE/SNF complex deficient carcinomas, as you know, are a very specific category of lesion because of being driven by a loss of that particular function in the gene. And this is either with SMARCB1 or SMARCA4. And you may say, well, what does SMARC stand for? Well, it stands for SWE/SNF-related matrix-associated actin-dependent regulator of chromatin subfamily B member 1. So this is clearly why we do not spell out SMARC every time we say it. We would lose time. time. So anyway, the SMARC deficient carcinoma category is definitely a very specific and unique group, actually taken out of the sinonasal undifferentiated carcinoma category where they were usually identified previously. So if there's any major study and they try to find them, that's the usual diagnosis for these previously. Interestingly, it is a biallelic inactivation of SMARC that is required in order to have the tumor develop, and it is very close to EWSR1. So in fact, this is where there was some initial confusion, because when the tumors were originally identified and FISH was performed, EWSR1 FISH was giving a false positive, and yet these tumors were not actually Ewing sarcoma. So they didn't look like Ewing histologically, and yet they were coming up with a Ewing FISH, and people were like, wow, that doesn't make sense. But then when PCR was done on those same cases, it turned out that there was no FISH, there was no modification in EWSR1, and they were able to identify the SMARC family. So most of these tumors are fairly high grade. Many of the patients still die from their disease in a relatively short time due to the clinical setting of the disorder. So there are three major categories: SMARC B1 deficient carcinoma, this is the basaloid plasmacytoid rhabdoid cell category, versus the SMARC B1 deficient adenocarcinoma. So you have a regular carcinoma that would be equivalent to previous squamous cell carcinoma category, and an adenocarcinoma group. This actually has, excuse me, yolk sac-like features. So it almost gives the appearance that this may have been a germ cell tumor as well. And then finally, the SMARC A4 deficient carcinoma group. This is another one that has rosette-like structures, nests, and rhabdoid cells that are less likely, but still lacking any glandular or squamous differentiation. So specifically, these are identified by a loss of nuclear INI1, which is the immunohistochemistry for SMARC B1, or for BRG1, which is the immuno for SMARC A4. So if you have a poorly differentiated tumor that is not being classified correctly, the pathologist should generally do an INI1 or BRG1 just to be able to get it into this particular category. You will notice a very remarkable plasmacytoid or rhabdoid type appearance where the cytoplasm is really pulled off to one side and is quite easy to identify. And of course, there are a number of different immunohistochemical markers that can be seen in this. I'm putting up this table as a differential for the rest of the small blue round cell tumor category. And yet here you will notice a loss of INI1. It is constitutively expressed in all normal cells, and so you have an internal control natively in it. I really like that, because whenever you're talking about a negative stain being a positive result and therefore putting it into a tumor category, I'm always a bit nervous and flustered by that. But in this case, there is such a nice internal control that no matter what happens, you're able to interpret it with ease. Now, just along that line, I'd said there was some updating with teratocarcinosarcoma. As you know, this is a very heterogeneous neoplasm with both carcinoma, sarcoma, and immature neuroepithelial elements. However, it does show loss of SMARC A4. So it was a decision of all of us to still keep it as a unique category, just because it does have this very unique histology of a primitive appearance with squamous differentiation or glandular differentiation, as well as areas of very well-developed sarcomatoid appearance to a mesenchymal component. And yet it is a BRG1 or SMARC A4 deficient group. So it isn't yet a category. As I said, this is kind of the SWE/SNF complex is still a little bit under development to say, is the driver of this the only thing that should be used to place it into a tumor category, or should it be used in context? If I can use an analogy, BRAF mutation, right? BRAF is present in papillary thyroid carcinoma, but it's also present in melanoma. And of course, if you want to go to a whole bunch of other lesions around the body, colon carcinoma, etc. So we don't use BRAF as the overarching family in which to place the tumor. We're still using morphology to place it and just commenting that it has that particular mutation. So I think that's where we are still with teratocarcinosarcoma as a unique entity, but recognizing that it may be part of the overall SWE/SNF complex deficient carcinoma group. We're all very familiar with sinonasal undifferentiated carcinoma, and I will say the number of times in which I make that diagnosis now is decreasing each year, because each of the tumors that have come out of this, such as the SWE/SNF complex or potentially nut carcinomas, means that they are now fewer in this particular category. So it's definitely a diagnosis of exclusion. It has a very characteristic vesicular open nuclear chromatin. It's very destructive. Here, I'm just showing an illustration of it involving bone. Here, you can see it involving several vessels in the sinonasal tract with the epithelium noted up here in the upper portion. But it is a very primitive appearing, large open vesicular nucleochromatin. Well, in this case, it needs to lack squamous or adenodifferentiation in order to put it into an undifferentiated category. And so by definition, it will be positive with a number of keratins, including pan-cytokeratin or CK7, but should be lacking in any of the squamous markers. And here I'm only illustrating two of them, CK56 and P40. It could just as easily have been P63. You will notice that there are isolated cells present at the periphery. This is part of the basal zone for these tumors, but it is not actually the neoplastic cells that are positive. And in this case, it is actually noted to be positive with IDH2. So I had mentioned just a few moments ago that IDH2 is considered to be an emerging category. We're not yet sure if that mutation is the only driver for this particular tumor. We certainly have identified IDH1 or 2 in several other tumors. I'll talk about them in cartilage neoplasms in a few moments in the larynx. So again, it's not a defining entity, and this is why, is sinonasal undifferentiated still best kept in that category, or should it be part of an IDH2 family? And we'll see how that resolves over the next several years. Another one of the new tumors that was included is the HPV-related multiphenotypic sinonasal carcinoma. It is a bit of a long-winded diagnosis, but it is trying to specifically address the fact that transcriptionally active HPV is the driver for this tumor that shows both surface epithelial dysplasia or carcinoma, as well as a salivary gland type, and most usually adenoid cystic type pattern. But it is a tumor that has an overall excellent prognosis. So in other words, its separation from adenoid cystic is actually very significant, because adenoid cystic over the next 10 or 15 years will certainly lead to the patient's demise with multiple recurrences, whereas the HPV-related multiphenotypic sinonasal carcinoma does not. So it is really important that that particular distinction be made. And if someone makes a diagnosis of adenoid cystic in the head and neck area without having done HPV-specific staining, or at least a P16 first, is not going to have a correct diagnosis necessarily. So here you can see, again, it's a very destructive tumor locally, but it is not one that tends to metastasize very frequently. You will notice here that it looks all over the world like adenoid cystic carcinoma. That nice cribiform architecture or Swiss cheese type appearance is very easily identified. This is what I would like to highlight, though, and that is it has squamous cell carcinoma either in situ, dysplasias of varying degrees in the overlying surface epithelium. So clearly both components are involved in this particular tumor. From the standpoint of the underlying neoplasm, it does really look like adenoid cystic. If you just looked at a single high power field, it even has these nice little ductules or tubules present within it. It has the retraction artifacts that you can see over here as it separates from the adjacent stroma. So it really is a tumor category that if you do not do any additional testing for it, you're never going to get to the neoplastic category. So you will notice that the myoepithelial group stains with either P4063, smooth muscle actin, or calponin, while both components will stain with S100 and SOX10, while the ducts only are highlighted with CD117. So interestingly, the MIB, which is the fusion usually identified in adenoid cystic, is actually positive by in situ hybridization or even immunohistochemistry. But when you do actual gene rearrangements or additional FISH studies, they are negative. So this is another point where just doing certain tests without following through the entire way is going to be misleading. Same thing with P16. P16 is strongly and diffusely reactive in several sinonasal tract lesions, but if you do not do additional high-risk HPV RNA in situ hybridization to confirm it, and in this case, it's almost, greater than 70% of them are associated with HPV-33. So if you do not have HPV-33 in the high-risk cocktail, you're not going to get it. And I can tell you just from the ordering patterns, outside organizations like NeoGenomics or ProPath, Mayo Clinic, etc., they do have an HPV 16-18 cocktail, which if you did would never show you this particular tumor because it would come back as negative. So this is where the specific testing that is done needs to be very well articulated and know what you're actually ordering before it happens. So this is not something where you can just sort of randomly say, oh yeah, do the high panel and you'll be okay. You need to make sure that it has HPV 33 in it. So this is an example of the P16. You can see that it's a really nice, strong, diffuse block-like reactivity in more than 70% of the neoplastic cells, both in the cytoplasm and in the nucleus. And then here is an example of that in situ hybridization, highlighting the neoplastic cells are expressing it. So it is a transcriptionally active HPV that is the driver of this particular tumor. So interestingly, I did say that this tumor has a much better overall outcome than adenoid cystic. And so if I can use by analogy, HPV-associated tumors of the oropharynx also have a much better overall outcome than those that are not HPV-associated. The DECAF2 carcinoma category is an emerging group. Again, we're not sure if this is the only definition of the disease. Ironically, it has a very, very low-grade appearance, and the vast majority of these cases are actually cases that were originally called either inverted sinonasal papilloma or some of them exophytic sinonasal papilloma, but they keep coming back and get more and more destructive, and ultimately they will metastasize. And in the metastasis, you're like, wait, how can a papilloma metastasize? And then when you do additional testing on these tumors, the DECAF2 is identified. So it is a very specific finding. Here is just an example, multiple papillary projections for this particular tumor. When you look at it, it seems to have a remarkably increased number of acute inflammatory cells. So that is actually one of the tip-offs that I use when I'm making this diagnosis. So I think you know that the sinonasal papilloma category does have inflammatory cells in it. And in fact, it's the transepithelial elimination of them that we utilize as one of the diagnostic criteria. But in this case, it doesn't actually form well-formed microabscesses. It's just sheets of these almost on a 1-to-1 or 2-to-1 ratio to the neoplastic cells. And whenever I see that now, my index of suspicion for a DECAF2 carcinoma is elevated and then proves out to be present if you do the FISH. There's several different techniques. There's a fusion FISH as well as a break-apart FISH. And again, it needs to be a very specific order in order to be able to identify it. This is an example of the fusion FISH, and there are only about 2 or 3 labs in the United States presently that do this. So you do need to kind of know how to order it in order to get a positive result. So let's move on to the nasopharynx now as an example. This really only had one major change, the name for the adenocarcinoma in that group. We decided to specifically add in low grade as the nasopharyngeal papillary adenocarcinoma. And that's just because most of these tumors never metastasize and go anywhere else. It's a local phenomenon, but still can be a destructive lesion. As you know, it is associated with Rathke pouch as its source of development. And so this is a unique case I had where you can actually see that that is the pituitary gland adjacent, and this is the rest of the low-grade nasopharyngeal papillary adenocarcinoma. You may remember that it stains with TTF1. So many times people thought this was metastatic papillary thyroid carcinoma, but it is not positive with thyroglobulin. And so that is one of the helpful features with this particular tumor. I know that people have called this papillary thyroid-like carcinoma. And again, anytime you have a name that says it's like something else, we tend to want to remove that and get away from it. So I think nasopharyngeal, which is the anatomic site in which it develops, and papillary adenocarcinoma is an excellent overall name for this, with the addition of low grade giving you some information about its clinical outcome. So for the larynx, you can see going from 43 to 21 to 10 diagnoses. And really the only thing that changed was removing a bunch of things, right? So all of the hematolymphoid and specifically the neuroendocrine. I think that was the major change here, was the removal of the neuroendocrine type tumors. As you know, the previous names for neuroendocrine carcinoma grade 1, 2, and 3 have now been replaced by neuroendocrine neoplasm or neuroendocrine tumor. And that's going to be a very different profile for you guys as you move forward. The 2-tier versus 3-tier system still remains quite controversial. US and South America, several of the Asian countries have gone to the 2-tier. 3-tier is still utilized within Europe, and I don't know when that will actually change, but still there is a major focus of trying to just get that to 2-tier. There was also the addition specifically of information around PD-1 and PD-L1 as they are expressed in tumors in order to be able to predict their outcome to targeted therapies. Now, for the cartilaginous tumors, we did not take up the atypical chondroid neoplasm of unspecified management or unspecified group, because that just does not apply here in the larynx. Interestingly, in the rest of the body, chondrosarcomas generally have IDH1 or IDH2 mutations. However, when you look at the chondrosarcoma category within the larynx, less than 10% of the tumors will have that particular finding. So it's clearly a different driver in the larynx than what occurs in chondrosarcomas elsewhere. And so this is the reason why that particular nomenclature has not been advocated here. And we still have chondroma, low, intermediate, and high-grade chondrosarcoma. So I think you're all familiar with the imaging, usually the posterior area of the cricoid cartilage, popcorn-like appearance, and then you can see it grossly, and of course the histology below. And when you look at the histology, it's a very irregular architectural loss of array of cartilaginous tissue. So you'll notice there's a background of ischemic chondroma in the background, and that is also one of the etiologic agents that can quite frequently be seen concurrently with laryngeal chondrosarcoma. So salivary glands, we were kind of remained neutral, but that's because there were several lesions that were dumped and several that were aggregated together. And so whenever I talk about salivary glands, I always like to kind of put it a little bit in context about how long they've been around. And so this is from the papal apartments in the Vatican City, and a painting called The School of Athens by Raffaello. Here is a more en face view of it. And you may say, well, what the devil does that have to do with salivary gland tumors? Well, I'm going to tell you, that dude in the far corner has a salivary gland tumor. So pathologists always like to go and see high power. So here it is. Look at that. He actually has a pleomorphic adenoma, and he was willing to show it to everyone rather than being the other way and turning his face away like you can see the angel has. Probably he has one on the left side and just didn't want you to see it. So, you know, salivary gland tumors really have been around forever. There are some new entities that we have added into this, and there are some that are both emerging as well as submerging. When I'd said these should be submerged completely, you know, everyone always talks about the emerging, but, you know, oncocytic carcinoma is not really an entity, right? Oncocytic carcinoma, if you do enough testing on it, is ultimately going to turn into something else. It'll be a oncocytic mucoepidermoid carcinoma. It'll be an oncocytic salivary duct carcinoma. It'll be something else. So that particular tumor should really go away. But, you know, at this particular point, it's still there as a submerging entity. And hopefully in the 6th edition will no longer be present. So we did add several tumor category designations with their specific rearrangement if it was now identified. So these are the canonical fusions or point mutations that are present in the tumors, and it's saying this is the one that is most frequently represented. Clearly, secretory carcinoma has things other than ETV6 and NTRK, but that is the one that is the most frequently identified in this tumor, and so that's why we have said most commonly seen. Cytology was also added to part of the definitions, and then of course we tried to harmonize the grading with high-grade transformation being included in all of these particular categories as well. So sclerosing polycystic adenoma has now been recognized as a true neoplasm with P10 mutations identified in this tumor, and it has a very interesting aggregation of fibrosis, cystic alterations, apocrine metaplasia, and then both ductal and acina proliferation, very, very prominent eosinophilic granules, which are being pointed out by the arrow here. So it is a newly recognized true neoplasm within the salivary gland. The same thing with keratocystoma. It's a very, very uncommon tumor. However, it does have a very irregular histology when you look at it, and places like this certainly give the appearance that maybe you're dealing with an invasive squamous cell carcinoma. But when you have that type of pattern in a patient who's 8 or 15 years of age, to call a primary squamous cell carcinoma in the salivary gland at that age would be just really remarkable. Not something I would ever do. But it turns out that the keratocystoma does in fact have a unique molecular driver for it as well. And that paper is actually submitted for publication, which is why I know this. So I can't tell you the name of it until it's actually out in press, but I'm hoping it'll be out in the next few weeks. Intercalated duct adenoma. This is a kind of hyperplastic or adenomatous proliferation of just benign appearing ductal epithelium. It really does look like the intercalated ducts, except that it incorporates some of the areas of acina differentiation, as I've highlighted here. So interestingly, When they're well circumscribed or encapsulated, they have an HRAS associated with them, and hence we call them an adenoma. When they're much more blended and hyperplastic in appearance, they actually have a CTNNB1 mutation. So there seems to be two different drivers with this particular tumor, and it is possible that these actually represent precursor lesions to either, if I can use the term in situ, and I don't really want to, but they are kind of the early precursors to either basal cell adenoma or even epithelial myoepithelial carcinoma, since they have the same findings. Microsecretory adenocarcinoma was added. As you will notice, it has a very specific anatomic site with nearly all of them in minor salivary glands, and also has a very unique fusion with the SS18. So as you may recognize, the SS18 is usually associated with synovial sarcoma, and yet here you can tell that that particular gene is a different fusion partner with MEF2C, and yet it forms a completely different tumor pattern. So again, this is where our molecular techniques are catching up to what we can see histologically in these particular lesions. Okay, let's go on now to the oral cavity. And if you think about the oral cavity, they actually added some non-neoplastic lesions. So necrotizing salometaplasia was added just because clinically it can look a bit like a tumor with the ulceration and kind of epithelial proliferation that can even give you a verrucous or papillary appearance clinically. And then multifocal epithelial hyperplasia was moved from papilloma. And finally, oral melanoacanthoma was also added, given how it can appear clinically. And then there were some changes to how the dysplasias and other lesions were identified as well, especially within the precursor category. So just to highlight, oral melanoacanthoma is not a neoplasm. It's just a reactive proliferation of epithelial melanocytes, but it gives you a thickened epithelium, is also the discoloration that can be seen clinically, and it is a remarkable mimic given how quickly it presents of a melanoma, and so it was included for that particular reason. Submucosal fibrosis has been included because it is also a precursor lesion to the development of carcinoma, especially those that are involved in betel nut chewing or tobacco use in the oral cavity as a quid product or a snuff. And so this really is a precursor type lesion that was recognized now, given the global nature of what the WHO book should represent. We did add the HPV-associated dysplasia. This is a very specific oral cavity representation of HPV, and it has these very remarkable dyskeratotic cells present within the epithelium that is completely atypical as a squamous cell carcinoma in situ. So in other words, it's a full thickness epithelial dysplasia, and when you do HPV testing, you can see an example of the P16 is strongly positive with transcriptionally active HPV present. I will tell you, though, this is a very, very specific histologic pattern, and it is a very specific finding in the oral cavity. So when we're dealing with oropharynx in a few moments, HPV is required to be done in every one of those cases. But that is not the case in the oral cavity. And in fact, this is the only time that I will ever do an HPV type testing of any sort. Carcinoma cuniculatum was added. This is a very unique pattern, very similar to verrucous carcinoma in the fact that it does not metastasize and is much more of a local phenomenon, but this very, very remarkable burrowing and endophytic growth pattern rather than being exophytic is quite characteristic. I will tell you the major difficulty with this is when a biopsy is done, it's going to go from here to there, and that's all you guys are going to sample, and therefore we will say atypical squamous epithelial proliferation, and you'll be like, what is wrong with that pathologist? Well, the thing is, we're not seeing this entire huge lesion that you are clinically. And so if that information is not included and you're giving a small superficial biopsy, it's never going to reach the diagnosis because there's not any cytologic atypia. So for the most part, there's no dysplasia. It's just the overall pattern of growth that results in this particular tumor classification. For the oropharynx, let me just say, you'll notice 2005, it was not included at all, right? So this was a terrible oversight. But anyway, 2017, 11 diagnoses, now we're down to 3. Hamartomatous polyp was added in this location, even though it is not truly a neoplasm, it does present as a neoplastic growth clinically. And then HPV associated and HPV independent. So previously, we had used the term HPV positive, and that just doesn't tell you anything, because what is it positive with? What is the HPV that you are testing? How is that related, etc.? So we decided that the associated and independent were better terminologies to use throughout, and that has been employed throughout the entire book. So when you're in the GYN cervix, it's the same thing. When you're in the genitourinary tract, penile carcinomas, etc., all of this has been standardized, so it is now HPV associated, used throughout. There is no carcinoma in situ within the oropharynx because there is a lymphoepithelium that is directly in contact with the adjacent stroma without any basement membrane intervening. There just is never a squamous cell carcinoma in situ, so that is not recognized in this location. Neuroendocrine tumors can develop in this location, and they are reported separately because they are part of that neuroendocrine carcinoma category I'm going to talk about at the end, but just recognize that they can develop here and be HPV either associated or independent. So let me just point out, here is an example of a tonsillar epithelium, right? Where is the basement membrane? Well, there isn't one, right? It just has the epithelium going all the way out into the adjacent stroma. Here's another example, very, very intermixed appearance to this, where they just completely harmonize with one another. So this is why when you have carcinoma development, it immediately gets into the lymphatics, into the lymph nodes so quickly, because there isn't a basement membrane for it to breach. And this means that they can be quite small. Here is an example of a tumor that's actually 2 millimeters. It goes from here to there, and that's the full extent of this particular tumor. And yet it resulted in a 4 centimeter clinical lymph node as the initial presentation of this tumor. So again, you can tell, were you to be doing biopsies, and this is the surface over here, if you did multiple biopsies over here, you would never actually get to this very deep crypt epithelium. And so this is why so commonly the biopsies will come back as being negative, even though there is still a primary tumor there if a tonsillectomy or adenoidectomy is performed. Again, most of these are very deep lesions. This is an example below the surface, and you can see that it is a non-keratinizing epithelial proliferation. When doing P16, you can see that it's a very strong reaction with P16. So there are many different reporting guidelines. The dataset reporting is very helpful. And again, this is something that you should be familiar with, because many times the clinicians will be the ones to ask for HPV testing, and yet you should know when it should be requested and what the parameters are for the ordering of that particular finding. Again, just highlighting the neuroendocrine carcinoma that can be HPV associated. Most of them do develop within the oropharynx, hence I'm talking about it here, but recognize it can occur anywhere within the upper aerodigestive tract, showing a very strong and diffuse both chromogranin and P16, telling you that this is actually HPV associated tumor. Let's now go on to the odontogenic lesions. You'll notice a slight uptick in the number of entities here. The new entities actually included some non-neoplastic entities, but part of that epithelial cyst type category. With significant reorganization, all of the odontogenic cysts that are of inflammatory origin, then going to the non-odontogenic developmental lesions, trying to harmonize the terminology for them was quite an undertaking. Adenoid ameloblastoma was added, segmental odontomaxillary dysplasia was added, and then of course the most significant was the TFCP2 rearranged rhabdomyosarcoma, which I'll talk about in a moment. And the goal of this particular chapter and why there was so much reorganization was trying to group them based on whether they were epithelial or whether they were hard tissue, mesenchymal, and then those that had both features combined, going from a benign to malignant. Now, I think one of the nice things is also the charts. I'd mentioned those at the beginning. Here you can see an example of such a chart where it really is a remarkable thing for you to look at to say, okay, what's the general age of my patient? Is it radiolucent? Is it mixed radiolucent or opaque? Is it just opaque? And which are the most likely lesions that would fall into that particular category? And so it is a nice way to look at it. Another is actually based on the genetic alterations that are seen based on the histology appearance. So all of the giant cell lesions have been aggregated, the fibroosseous lesions have been aggregated, and then between the benign and malignant cartilaginous or bony lesions, with those little graduated scales going out to suggest the decades in which they are most likely to present. So I think these type of tables and the associated molecular alterations are very useful to be able to kind of get a general feel for what category of tumor and entity you may be dealing with. So surgical ciliated cyst is just iatrogenic, really, in all senses. It's because the person has had multiple surgeries, and now there is a ciliated epithelium present within it, usually in the maxilla, because that's where the surgery has been done. And, it's just a non-neoplastic lesion that was included just because it looks radiographically like some of the other neoplasms or cyst-like tumors. The adenoid ameloblastoma has been added as well. Just know that this is just a pattern of ameloblastoma that has a very specific adenoid appearance to it with duct-like structures. But again, it has been shown to be BRAF pathogenic variant associated, not necessarily always with BRAF V600E, but some of the others, and therefore it is still within the ameloblastoma category. Segmental odontomaxillary dysplasia. Again, this is more of a reactive and non-hereditary developmental disorder, but it does have this kind of unique vertical trabeculation and coarse calcification radiographically. And of course, bone biopsies will show irregular bony spicules and reversal lines, but often it is something that will resolve on its own. The TFCP2 rearranged rhabdomyosarcoma is really something that has startled nearly all of us, because it is a rhabdomyosarcoma developing usually within the jaw bones or the immediately adjacent soft tissue. But mandible, maxilla, and skull bones are the most frequent anatomic site of location for this particular tumor category, and the majority of them are in young patients. So previously, these were called spindle squamous cell carcinomas, and of course managed as such, and wondered why the patients had such a poor outcome. And that's because it is actually a rhabdomyosarcoma, and as you know, the management for rhabdo is completely different than for squamous. So why is that? Well, it stains positively with keratins. So the AE1, AE3 is positive in these particular tumors. And so if you're only doing one marker, you're going to be wrong in this particular tumor, not recognizing that the MyoD1 or myogenin or even ALK is positive in these tumors. So here's an example just on low power. You can see that it does have a spindled to kind of epithelioid morphology, very identical to what you see in a spindle squamous cell carcinoma. And if you just did a keratin, highlighted here, you can see it's a strong and diffuse reaction in the cytoplasm. So if that's what I got, let's say 25 years ago, I would say, oh, spindle squamous cell carcinoma, let's move on to the next case. However, if you did a panel approach, you would see that the myogenin is positive, as is the ALK. And so it's now treated differently, and the patients have a much better prognosis now that they are being managed correctly. So whenever I have a young patient with a spindle to epithelioid neoplasm involving the jaw bones or gingiva, this is the approach that I now take with these particular cases in order to be able to correctly classify them. And I can tell you I've made this mistake. I've gone back to 2 of my cases in younger patients that I had diagnosed more than a decade ago and done the additional stains and found that they were in fact positive with myogenin and ALK. So it is something where until you have the particular category of tumor, you may not always be correct. And it also means that you cannot just rely on a single immunohistochemical stain. I know that we kind of like to save money, but I'm going to tell you each immuno is about $50. A CT is probably $950, depending on how much you get reimbursed. So I'm doing all the immunos I need in order to be able to work up that case without worrying about what's going on with the finances in the background, because it clearly is going to make a huge difference to the overall patient outcome. Okay, tumors of the ear. Well, I was involved, as you know, in all 3 of these editions, and I was younger at that time, so not nearly as vociferous as I am now. I know that's very hard to believe, but there are a bunch of new entities that are included. Well, actually, it is not new entities. It's they were in the 3rd edition, but in the 4th edition, there was a much more dictatorial approach to the way in which the book was put out. And so these entities were not there, and then they were included back now in the 5th edition. So there are some, quote, new things that actually were not new because they've just been omitted in the 4th edition. I think whenever you look at these things as well, just remember they have been around for a long time, right? So this is actually a mummy head estimated to be about 600 years before Christ. And when you look at the CT of that, there you can see this bony lesion, and it's actually an example of an osteoma. So even though we're including osteoma now in the ear, it's been around for a long time, just so you can see the context. So one of the things that is interesting to me is nomenclature change over time. So yet again, this poor damn tumor has undergone a name change. So there are probably more names applied to the middle ear neuroendocrine tumor than there are actual tumor cases or tumor reports. But anyway, this is just a short highlighting of the number of names that have been used. We now recognize that it is, in fact, a neuroendocrine type tumor that was there with the neuroendocrine adenoma of the middle ear, or NAME, which is the one I put on this particular tumor years ago. But it is a neuroendocrine tumor, right? So glucagon is expressed, islet-1 is expressed, SATB2, SSTR2A is present as well. So this all talks about hindgut differentiation, if you will. And so it is a genuine neuroendocrine tumor. Because it is so inculcated in the literature and has had so many name changes, I begged that the people would not move it into the neuroendocrine tumor category as a separate chapter yet, and include it still here in the ear. And so, at least for this edition, it is still in the ear as a neuroendocrine tumor, but next edition, in the 6th, it's definitely going to be with the rest of the neuroendocrine tumors and will have been removed from the ear and temporal bone chapter. Okay, soft tissue lesions. Lots of different changes in that particular regard. First of all, it's because they've been removed from everywhere else except when they are site-specific. So, you know, if you think about glomerulonephrocytoma, biphenotypic sinonasal sarcoma, both of those are sinonasal tract lesions. They have remained within the sinonasal tract chapter, and the reason for that is they don't occur anywhere else. So in other words, glomerulonephrocytoma does not occur in the salivary gland or in the larynx or somewhere else in the body. So the idea of trying to keep it separate had logic, and because it is only in that anatomic site, it remained. But for the rest of the head and neck area, we did try to aggregate all of them, and you'll notice there are several new entities and rechanging of names or giving new names to some of the previous lesions as well to be a little bit more accurate in their classification. So the EBV-associated smooth muscle tumor, this is a lesion that is usually associated with someone who is immunodepressed, and quite frequently it is related to transplant history. So again, if a patient had a kidney transplant 10 years ago and now develops a smooth muscle tumor somewhere within the head and neck, usually the larynx, although oropharynx and orbit can be affected as well, it has a very unique histology. It's very, very tight spindle cells, blunt-ended nuclei, but they can have nuclear atypia and increased activity, and therefore it is something that looks like a leiomyosarcoma. And because multifocality is present within this tumor category, it'll be misinterpreted as representing metastatic disease. And so the management will be different than just local management of it, because that is all that is really required. So by definition, even though it's a smooth muscle-based tumor with the associated immunohistochemistry, you do need to have the EBV performed as an EBER in situ hybridization. So here you can see very, very short fascicles below an intact surface epithelium of the larynx. Desmond is strongly positive, and here is the required EBV being represented here by an EBER as an in situ hybridization technique. So again, if you don't do the study for EBER, you're never going to know that it's EBV associated, and putting it into a different category of lesion. So I will say most of these were called leiomyosarcomas beforehand, and always wondered why you know, such a bland appearing tumor in some cases would represent metastatic disease. And now we realize that it's not metastatic disease, it's just part of multifocality because of the underlying immunosuppression in these patients. The phosphaturic mesenchymal tumor is now recognized to be through the production from fibroblastic growth factor 23, and it's anything that causes a tumor-induced osteomalacia. So there's several different tumor categories that fit into this. Probably glomerulonephrocytoma is actually one of the most common, but just recognize that this as a classification of tumors has a very, very associated finding with leaching of calcium in the periphery, and also having either adipose tissue or more of a myeloid phenotype present somewhere within it. It does have calcification, as you would expect from a tumor that is associated with calcium abnormality. However, in the head and neck, that tends not to be present very frequently. And that fibroblastic growth factor is quite frequently present in these tumors as well. So a radiographic example of such a lesion, a spindle cell proliferation here, another example with this very flocculent, grungy type appearance to the calcification. You can see some calcification immediately below it as well. And then here's another example of those kind of flocculent calcifications, a much more giant cell appearance to the adjacent stroma, giving you a similar finding to what you would see in a giant cell lesion. However, here you can see that fibroblastic growth factor strongly expressed within the neoplastic cells through the CISH technique. Extraskeletal myxoid chondrosoc. Well, you know, this is like just the worst name ever, right? Because it is extraskeletal, so that probably is not so bad, but it is not a chondrosarcoma at all. And in fact, it is associated with the NR4A3 gene rearrangement with multiple different fusion partners, most frequently with EWSR1, but can be seen with TAF15 as well. So unfortunately, this has a very myxoid, very nodular appearance, and so mimics so many other tumors and does not have a specific immunophenotype. So very frequently, this tumor is kind of in this, I have a myxoid NOS lesion, how am I going to come up with an accurate diagnosis? And so here you can see such an example. It is fibrous connective tissue septa separating it out. You have this myxoid appearance that looks almost like a myoepithelioma or myoepithelial carcinoma. Areas of the myxoid change, sometimes even simulating adenoid cystic carcinoma. So there are a number of different neoplasms that will come to mind when you look at this, perhaps even a pleomorphic adenoma that's mucinous in its appearance. And yet it does have a very well-defined EWSR1 present within it. And this is an example of a fish study showing a break apart for it. Now, I'm just putting this in as kind of a reminder that we do get things out of nature. So this is a jellyfish from a trip that I made up to Monterey Bay. And the gene was taken from this fluorescence to create fish, which is what we use now in our assays. So in fact, this is an example of jellyfish providing the fluorochrome for our fish. So I think it's kind of a nifty correlation. GLI1-associated tumors. This is a newly recognized group as well. Know that the GLI1 alteration is seen in these tumors that also have a very uncertain histogenesis. There are fusions in about 2/3 with amplifications in the remaining tumors, with about 40% of them occurring within the head and neck, either in the tongue or oropharynx most frequently. So this tumor projects into the vessels and will have vascular invasion. Sheet-like pseudo-rosette cord reticular pattern with small cells that can be kind of epithelioid in appearance. And in fact, they will be P16 positive. So when they occur in the oropharynx, sometimes they will be misinterpreted to be oropharyngeal carcinoma. They do have a overlapping variable and patchy immunohistochemistry. So again, it's very difficult to come up with this diagnosis de novo. And so you may just get myxoid mesenchymal or myxoid epithelial mesenchymal tumor or something like that without actually a definitive diagnosis unless you actually do the GLI1. Now, we noted recently that the DDIT3 is a surrogate marker for this. And so if you don't have GLI1 available, that particular fish study can be performed and it will show that it is lost in this particular case because it's right adjacent. So here you can see an example of vascular invasion with this tumor. Another example here giving you almost a paraganglioma-like appearance. So frequently that was what was misdiagnosed for this tumor. Another example here giving you that more myxoid appearance with a fenestrated overall architecture similar to what you would see in either a myoepithelial tumor such as PA or myoepithelial carcinoma, and another area here with those cord-like appearances to some of the vessels, and yet this is showing either amplification or rearrangement of GLI1. So it really is a very specific tumor category, and we have now added that into this particular site as well. As you know, the adamantinoma-like Ewing is a very specific category that shows a squamous differentiation in the tumor, although it isn't in every case. But immunophenotypically, it shows a very characteristic squamous epithelial differentiation with CK-pan, P40 and or P63 strongly reactive. So again, if you're only doing one marker, you can certainly be deceived in what you would have as a diagnosis for this lesion. So here you can see very primitive appearing cells, small but easily identified nucleoli, often slightly eccentric against the membrane of the nucleus. A lot of histologic and immunophenotypic overlap with other tumors within the small blue round cell category. And you can see that I'm showing that and highlighting it with the various markers that are being performed across the board. So if you did P40 and CK56, both of them recognized to be epithelial markers, and that's all you did, including a CK-pan, let's say, you would say, oh, this is a poorly differentiated squamous cell carcinoma. And so, in fact, that is what these have been called. And yet, when you add either CD99 or the more specific NKX 2.2, you will see that this is now much more likely to be present within the adamantinoma-like Ewing sarcoma category. So once again, I'm just highlighting that the days of doing 1 or 2 immunomarkers to be able to get to a diagnosis, and if that's all you see on your diagnosis when you get it back from pathology, maybe you should have a discussion to say, you know, are there other things that maybe should be considered in this differential, and are they tumor categories that we can consider and maybe have a different management. Ewing sarcoma is systemic disease, right? I mean, that's how we view it. And therefore, chemotherapy and radiation is used as the management for that particular group, very different from what you would do as a surgical resection for a squamous cell carcinoma. So the hematolymphoid lesions has also slightly increased. As I've reiterated all along, they are very, very specific and therefore aggregated into a specific chapter all on their own. The EBV mucocutaneous ulcer is not considered to be a neoplasm, but because it can present with this ulceration and also having EBV associated with it, we decided to include it in this chapter since it can be a mimic of malignancies and needs to be recognized, usually in immunosuppressed patients of some sort, but it does actually resolve as a self-limited disease. The IgG4 related diseases have been included in this particular book as well. And as you know, this is not a neoplasm, but it is very specifically related to IgG4. And all of the criteria have been included with this particular category. In fact, multiple charts are included in this as well in order to be able to come up with an accurate diagnosis for these lesions. So the storiform fibrosis that is present with this, the vascularity or obliterative phlebitis that is identified is highlighted here. And of course, you need to have plasma cells that are at least more than 100 per 400 cells per 2 square millimeters, or greater than 100 in a high power field if you want to use the old criteria. And again, the ratio of IgG4 to IgG needs to be greater than 40%. And here you can see such an example. So it's nice that the IgG4s have been included as an example, since it is a tumor factive type lesion. I mean, if you think of this developing in the submandibular gland as a quote old Kuttner tumor, this is clearly clinically to you a very rock hard lesion that mimics a neoplasm. Things like Erdheim-Chester have been included as an example with the xanthelasma type lesions, very specific criteria given out for each of the anatomic sites where they may develop and what you're expected to see. All of the various mutations have been classified and aggregated so that you're able to see what the most common ones are. And then, of course, the histology is also included around the histiocytic development with CD163. So it is a nice inclusion in this book as well. Melanocytic lesions, well, you know, we keep decreasing every time, and now it's just melanoma, right? So mucosal melanoma, this is an example of a junctional atypical melanocyte present in a otherwise metaplastic squamous epithelium. And then you can see the melanoma below the surface. That characteristic peritheliomatous distribution of the neoplastic cells is quite characteristic for this tumor. And recognize that there are a number of different immunohistochemistry markers that can be done. This is probably the tumor where doing more rather than fewer is helpful, because sometimes they don't express all of them or may not express them in a very strong fashion. I have included PRAME here because everyone wants to, you know, have the new antibody on the block performed. Preferentially expressed antigen in melanoma is what PRAME stands for, and yet it is present in all sorts of neoplasms all over the body, so it is not, in fact, preferentially expressed in melanoma at all. But if you have a differential that you're trying to work through, and you know that it isn't positive in other tumors, you could potentially do it as a final antigen marker. Recognize again that there is a different driver for mucosal melanomas than cutaneous melanomas. So the NRAS and KIT mutations are much, much more commonly identified in this location rather than BRAF. And so when you're doing a request for molecular evaluation, don't just say BRAF, because it's going to come back BRAF negative, and then you may say, oh, well, we cannot do any sort of targeted therapies, and yet including the others that are more common would be of value. So just to highlight the various multiple different melanocytic type markers that can be performed. And of course, I'm including PRAME just so you've seen one. It's a nuclear reaction, so it is quite easy to be able to identify. Lymph nodes. Well, in this particular, or lymphoid lesions of the head and neck, as a whole. So lymphoepithelial cyst and branchioma was added in this case. As you know, branchioma used to be called ectopic hamartomatous thymoma. It's a complete misnomer because it's not hamartomatous and it's not a thymoma, and we recognize that it is a neoplasm at this particular point with specific alterations in KRAS, and of course carcinomas can develop within them as well. So it has a mass-like appearance, usually in the low supraclavicular, para-supraclavicular region. It has a aggregation of both spindle cells, myoid cells, and epithelial cells blended with adipocytes. So each of these elements can be present within the tumor. Sometimes the smooth muscle-related proliferation is much more frequently identified. Germ cell tumors, well, it wasn't included at all in 2017, so now we added it back in. And it's just to say germ cell tumors can occur in the site, right? I mean, it was not a very specific definition for these. We did need to exclude the SMARCB1 deficient carcinomas. As you know, several of those can have a germ cell-like pattern, as I indicated in the sinonasal tract. And so it is important to at least exclude that particular finding. Metastases to the head and neck, of course, were also covered. And here you can see that this is a very broad group of anatomic sites that can be affected. Multiple different tables were included, and in the tables were the most specific tumors that metastasize to that location, and then the immunophenotypic markers that would be relevant in being able to come up with the correct diagnosis were they to be performed. So a very comprehensive approach to metastases. Lots of references are included in this particular chapter as well. And here are a couple of examples: metastatic prostate carcinoma with NKX 3.1 strongly positive, and an example of metastatic renal cell carcinoma with PAX8 being distributed in the nucleus of this group. So I am going to go about 5 minutes over here because I do want to talk about the neuroendocrine neoplasm category, which was probably the most significant finding in this particular book, because it is one of the most significant changes. They've all been pulled from everywhere else and included in this particular group. Paraganglioma as one, and then neuroendocrine tumors divided into neuroendocrine tumor grade 1, 2, and 3. They are not yet site-specifically defined because of the aggregation and harmonization of the nomenclature, but definitely is something that can be done. And neuroendocrine carcinomas between small cell and large cell. Merkel cell is a neuroendocrine carcinoma, but is a very specific signature to that particular tumor, and so is an entity on its own. So sort of by definition, they all arise from the dispersed neuroendocrine system. They need to have both epithelial as well as neuroendocrine differentiation. And interestingly, functional imaging studies like the dotate PET-CT can be used for this particular lesion, both as an identifier as well as potentially highlighting that they are active and therefore would respond to targeted therapies. So here is an example where you can see multifocal disease with the dotate PET-CT in both of these examples. Here is a highlighting now of how we separate between them. So NET1 or neuroendocrine tumor grade 1, no necrosis, mitoses of less than 2 per 2 square millimeters. Grade 2 sometimes have necrosis, and then 2 to 10 mitoses, and then greater than 10 mitoses with necrosis is a NET3. So I can tell you that the NET3 category needs to also say that there is intact retinoblastoma and an intact P53, because that's one of the separators between a high-grade neuroendocrine tumor versus a neuroendocrine carcinoma are some of these alterations seen immunophenotypically and not just in the pattern. However, we do need to have neuroendocrine type features histologically in order to be able to put it into this particular category. So fantastic rosettes here. This is an example of a laryngeal neuroendocrine tumor grade 1. This used to be called neuroendocrine carcinoma grade 1. And now that name is completely gone and is replaced by neuroendocrine tumor, because we know that this is a different tumor classification, a different tumor category. Another example of a grade 1 NET involving the larynx. Now going on to grade 2, still in the larynx, you can see now that it has a more epithelioid morphology, even sometimes giving you a gland-like distribution to these lesions, a bit more primitive in its overall appearance. Nuclear pleomorphism is usually quite easily identified. And then, of course, here is a neuroendocrine tumor grade 3. This used to be called neuroendocrine carcinoma grade 3 and now is no longer in that category. So you'll tell multiple mitoses. I mean, I'm highlighting just a few of them here, and you can tell way more than the number that you would see of having more than 10 per 2 square millimeters. Different immunophenotypic evaluation. Obviously, keratin is positive in these neuroendocrine tumors. And here you will notice an example of chromogranin, but calcitonin can also be expressed in these and is not related to anything from the thyroid. So it is an aberrant expression of this particular marker. Likewise, TTF1 can be expressed in these tumors and is not related to a tumor metastasis that is metastasized from the lung. And of course, as I mentioned, the retinoblastoma is intact in this particular group, which is why you can still separate it from a small cell carcinoma or large cell neuroendocrine carcinoma category. So let's now go into that. The majority of these do still arise within the larynx by far and away, with the remaining 35% in the sinonasal tract. So the neuroendocrine carcinoma category is something that generally is still associated with tobacco use, although, as I mentioned earlier, the HPV association can certainly be seen when you are dealing with oropharyngeal lesions. The neuroendocrine features must predominate. So if you don't have that histologically, just having neuroendocrine expression alone in a patchy or weak fashion is insufficient to get to a diagnosis of small cell carcinoma. So it needs to be cells that are about 3 times the size of a lymphocyte, a hyperchromatic nuclei. Often there's loss of cell borders. They have cannibalization of one another. They'll coat one another. They have molding against one another. So it's a very specific histologic appearance. Large nodules of tumor here, or islands of tumor, nests of tumor, if you will. They are often crushed, as you can see here. So that crushed artifact is one of the things that we use to highlight the diagnosis. An example here of very, very inconspicuous nucleoli, because the small cell carcinoma category tends not to have prominent nucleoli. And then you will notice needs to have both the epithelial as well as neuroendocrine markers present with an intact, with a loss of P53 and retinoblastoma. So here you can see an intact keratin. Usually the keratin is more in a dot-like or Golgi pattern. So you'll see there are multiple little dots in the cytoplasm of this lesion. That's quite characteristic for this tumor. The same can be seen with synaptophysin or something like INSM1, one of the newer markers that is recognized in the neuroendocrine classification. Retinoblastoma is universally lost in the neoplastic cells. Since it is constitutively expressed, again, you have an internal control that allows you to make that particular interpretation. Very high Ki67 proliferation index, usually it's greater than 50%, sometimes 70 and 80%. And as I already suggested, you may have association with transcriptionally active HPV, especially when it occurs in the oropharynx, as illustrated by this case. The large cell neuroendocrine carcinoma group is also recognized. Different histology where it has a much larger nucleus, much more prominent nucleolus present within it, and of course is equally as destructive with lymphovascular involvement and perineural involvement and tumor necrosis. Again, it's going to have the same immunophenotype as the small cell carcinoma category. So let's now talk a little bit about paragangliomas, just to say that the somatostatin-based therapies or peptide receptor radionucleotide therapies can be used if you're able to identify that they in fact do have SSTR2 receptors present within them, which they do. So it's kind of a nice analogy to what can be done radiographically and what can be seen histologically. As you know, many of these are associated with germline mutations, and SDH family of group is SDH family is probably the group that is most frequently involved with either D, B, or C, most frequently identified in the head and neck area. And so this is the reason for doing SDHB immunohistochemistry on these patients. Bilateral tumors here seen radiographically, and of course here is a old technique with fluoride 18 present here, but still giving you the example of multiple different lesions present in this patient, including one in the mediastinum. Many times you guys will have done some sort of embolic therapy for these, especially when they involve the carotid or perhaps vagus area involving the ear and temporal bone. Tyrosine hydroxylase is quite frequently positive in these tumors, and here you can see just an example of the newer marker with SSTR2A highlighting what you can see as a radiographic nucleotide as well, and of course loss of SDHB in this case. So we actually only do SDHB immunohistochemistry because that actually represents all of the families and will be lost whether it is SDH A, B, C, D, or F. So it is a nice marker to be able to do to detect that particular loss on a genetic basis. So speaking of genetics, let's end with the tumor syndromes, just to highlight that, in fact, those that are inherited here in the head and neck, 15 syndromes generally present with head and neck manifestations most commonly, and that's why they were included in this area. And so, you know, nevoid basal cell carcinoma syndrome or Gorlin syndrome, I thought I would just highlight here, as you know, the major and minor criteria, very specifically related to the sonic hedgehog pathway, with patch 1 as the most frequently identified mutation. Clinically, multiple basal cell carcinomas, the pits in the palms or plantar areas, having a medulloblastoma or calcification of the pulse cerebri. And then, of course, for us, multiple odontogenic keratocysts, as you can see here, often having areas of daughter-cyst relationship. So with that, I'm going to end and hope that you have enjoyed this exceptionally whirlwind view of what goes on with the upper aerodigestive tract in the head and neck. And we'll be happy to stay on and take a few questions if anyone is still listening. Thanks so much.
Thank you so much, Dr. Thompson. That was an incredible whirlwind, like you had mentioned. It is, I guess, one of the takeaways was one of the main takeaways I noticed that it is quite humbling how much the diagnoses have changed over time, how easy it is for us to miss something like what is now rhabdomyosarcoma was previously spindle cell, squamous cell. And it's just a reminder that we need to constantly be vigilant, staying up to date with the new classifications as they're coming out, and continue to work with our head and neck pathology colleagues closely and learn to trust one each other and kind of question our own assumptions of what we thought used to be the diagnosis in the past to give the patients our best care. Well, and yeah, I guess, does anyone have any questions at this time before we move on to the next hour?
So Raymond, let me just add to that for a second, and that is many times it's the clinician that has more information that isn't given to the pathologist that once it is can actually change that paradigm. So I recently had a case where it was called adenoid cystic carcinoma, and the clinician was like, oh, wait, don't you think this could be HPV related tumor? And then it was like, oh, yeah, it could have been that. And then the additional studies were done, and it was able to document that new tumor, which of course means the patient is going to have an excellent overall prognosis. So I do think that the clinician's view of what is going on, either radiographically or clinically, or what other things they may know about the patient. I mean, you would see that there was some sort of syndrome association if you see 25 basal cell carcinomas on a patient who's only 20. Whereas if you don't give that information to the pathologist, then they're not going to know when they get the keratocyst that, oh, this is part of a syndrome, and maybe this is the first manifestation that we need to document. So I do think the relationship between the clinician and the pathologist is amazingly underrated, and really should give a lot more credence to being able to get to the correct diagnosis, because most times you guys know what it is.
Interesting, yeah. Testament to needing to communicate better between clinicians when we're so busy. I guess taking that time to really figure out what we need to communicate is important too.
Yeah, when I see clinical diagnosis and it's blank, oh my goodness, you know, my blood pressure goes up and I have a seizure fit quietly, and then I get on the phone and try and find out what's going on.
All right, well, let us all unmute our microphones for a moment and give a round of applause to our guest speaker, Dr. Lester Thompson.
Thanks very much, you guys. Have a good day and don't work too hard.
Thank you so much. That was very enjoyable.
And I guess you can listen to it again at half speed and maybe get a little bit more out of it the second time around.
Yes.
Okay, take care. Thanks, you guys.
Thank you. Take care. Have a good day.